All right, so let's move on to medications. One of the first things that we reach for when we diagnose somebody with diabetes is, of course, metformin, which works predominantly here. And essentially what it says is, hey, cool it. We don't need all that sugar. Works very nicely. Does a great job. It also has a little bit of an effect out here. Helps with a little bit of insulin resistance and reduces it a little bit. And it does a very nice job, and we don't quite understand the mechanism of how it does it, but it does quite a nice job of helping to minimize weight gain. Unfortunately, in a sizable proportion of people, there are some side effects that aren't the greatest. Gassiness, diarrhea, stomach cramping. You'd be amazed how many of your patients haven't actually associated those symptoms with taking the metformin. The tendency is, as I've found as a primary care providers, they put the person on metformin and they keep just sort of notching it up, trying to get their diabetes under good control, which of course is what the guidelines are telling us to do, without really asking if they're tolerating it okay. And I've had a number of people come in. I, by the way, run a diabetes service where people are referred to me to be seen, and the number of times I get a person who's on a fairly high dose of metformin and does not realize that that these symptoms that they've got are actually associated with the pill. Very dose dependent. You can just drop them back and the symptoms will go away. Do not expect that if you put them up, they get the symptoms, and you keep them up there, that the symptoms will go away. They will not. You just need to find where they're going to be the most. One of my most moving sessions was a gentleman. When I talked to him about the side effects, he burst into tears. And he said, my God, I've not been able to go to the movies for the last 4 years. I am so embarrassed with the gas that I get. I had no idea it was my metformin. And it's like, great, let's find something else for you. Do please keep asking your patients, how are you doing with the metformin? By the way, and this is purely not an evidence-based comment, it's purely my clinical experience, I have found that the more a person is having side effects from the metformin, the more I should have a red flag going up. Maybe they don't have type 2 diabetes. Okay? Other class of drugs are the sulfonylureas, or the glitinides. These work predominantly, in fact this is the only place that they work, is at the level of the pancreas, and essentially they get the whip out and they say, come on, we need more insulin. They do a beautiful job of helping a pancreas to increase their insulin production if the person doesn't have a whole lot of pancreatic insufficiency. There is no point, obviously, in giving a person these drugs if they've already got a significant amount of their function lost. They also have some limited lifespan. This is the one drug that after 4 or 5 years, often you find they no longer respond very well to it. Well, that's because of progression of the disease. There is also a group of people who do feel that there is some evidence that it does perhaps shorten the life of the pancreas. It is a very debatable point at this time, but there are a group of people who do not necessarily prescribe these drugs. There's another group that are very happy prescribing these drugs. Somebody had a question.
I was going to ask whether it was thought that it was
It's still debatable. Yeah. Yeah. Yeah, there's arguments still being had out there, and definitely there are classes of, I'm in this boot camp and they're in that one. And studies seem to come out a little bit on both sides, although it's very clearly agreed upon that there is limited life in their use. All right? No other benefits. The sulfonylureas, of course, whipping that pancreas essentially 24 hours a day. So independent of food, you're getting the pancreas being stimulated to produce insulin. The glitinides are more associated with food intake. All right? Another class of drugs that we have are the glitazones out here, your rosiglitazone, your pioglitazone. 'Cause, 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 And essentially they're working at the level of the gates and they're reducing insulin resistance. And once again, if the person doesn't have insulin resistance, they're not going to do a very good job. If the person's got insulin resistance, then they may work very, very well. Pioglitazone and rosiglitazone have all sorts of other added benefits. They lower triglycerides. They increase HDL. All right? Unfortunately, very recently, there is some research coming out that is strongly supporting the fact, particularly in women, that it causes osteoporosis, which is making people very nervous about putting them on such a long-term drug. And then combined with the studies that came out on the rosiglitazone 3 or 4 years ago that were suggesting that there was some increased risk in cardiovascular events, that maybe these weren't the beautiful star drug that we thought that they were going to be. They also tend to cause weight gain, particularly fluid weight gain, and so contraindicated in anybody who's got significant heart failure. And usually when you bring that up with a person, the last thing they want is to, actually, I don't want to gain weight. I've got that problem already. And so it's becoming less and less of a popular drug, and I find very few patients actually reach for it. There is also very, very recently, at a recent conference, a concern that it also might be contributing to an increased risk of bladder cancer. And we're waiting to see the final call on that one. So we're all feeling a little bit nervous about the glitazones at the moment. We then have a whole slew of drugs. You do, we don't in New Zealand. We only have sitagliptin, but you've got saxagliptin and linagliptin and vildagliptin, I think are the ones that you've got here, and they are all working at this level here. And essentially, they're a beautiful drug, actually. I mean, we do have them available in the sense that the person has to pay for them. They're not subsidized by the government. When the person eats and the food comes down here, that's at the time that the drug kicks in and works. So it is dependent on the food intake. And of course, it helps this gut endocrine system to kick back in and perform these 4 duties. The beautiful side effect with that is not only a reduction in HbA1c because of the increase in insulin production, but of course there is also associated weight loss, which everybody's ears prick up when they hear that. And it's anywhere from 1 to 4 kilograms per month. And I've certainly seen 4 kilograms come off in a person who's morbidly obese. So a beautiful side effect for that. The caution that has gone along with these guys is pancreatitis. Not that I've ever seen that personally, and I think it's more of a fear at the moment out there, and they're not sure whether that's just because there's an increased risk of pancreatitis in people who are obese and have diabetes anyway, or whether in fact there is literally a more of an increase because of these drugs. Of course, we don't have any long-term data on them because they have not been out that long. The other drugs that work at this gut endocrine level, of course, are the xenotides, the Byetta, and you've got another one that's blanking me at the moment but is in your manual. All right? Acarbose is another drug that works on the gut system. I don't know how many of you still use this drug. It's not so popular these days because of the side effects. Essentially what it does is it prevents a particular enzyme from working at the level of the gut. That enzyme is about breaking down complex carbohydrates. So when the person is eating their complex carbohydrates, they don't get absorbed. And so the person basically has a malabsorption problem going on. And that's why they get the gassiness, the crampiness, and diarrhea that goes along with it as well. Some people like it a lot, but it tends to be less looked at. I know I've missed some of the drugs out, but these are the most common ones that will be covered. The others are all in your manual there. Any questions about pills? Does it make sense to you that when you're looking at the medications, that they're actually targeting each one of the areas that there is a pathology? And in fact, that's just what's happening is every time we discover a new pathology, the pharmaceutical companies get on their little treadmills and they come up with something beautiful that's targeting a particular area. And the truth of the matter is that I have presented to you here, as messy as this picture looks, I have presented to you a very simplistic representation of what's going on and what we've got available to us. There are other drugs that are right on the brink of coming out that are targeting the kidneys, where there is another pathology that goes on, and we could go on, and you're going to find that over the next 5 or 10 years, I don't think the rate of the number of drugs that are going to come out is going to slow down at all. I cannot urge you enough to create your own, I call this my coat hanger, to hang your information on as it comes flying at you. You need to be able to put it somewhere so that you've got an organized way of thinking about it and an organized way of presenting it to the patient. Because after all, if you're going to do patient-centered care, then you absolutely must share with them every bit of knowledge so that they can make the choice as to what's going to suit them the best. All right? Aside from the pills which are targeting the areas that could go wrong, we've then got the ability to replace the system, and that, of course, at the moment is insulin. And we're really lucky these days. We have the ability to replace this part of the system, and we have the ability to replace that part of the system. And today I am going to tell you that there are only 2 insulins, and you're going to look at me going, are you crazy? There are hundreds of them out there. There are only 2 insulins. There is a basal insulin. One that most closely resembles a basal insulin is of course, glargine. 1 shot a day, drip, 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 and it's matching, if you've dosed it right, it's hopefully matching what the liver is giving out. And then we have a second insulin, which is the bolus insulins. And the ones that we've got that do the best job of this are, of course, Apidra or glulisine, Aspar, and Lispro. Humalog, Apidra, and Novolog. There is another talk that I'll be giving on all the insulins so that you can understand them, but what I want you to truly come out of this is that we have 2 insulins, a basal insulin and a bolus insulin, and they're about replacing the system. We can go one step further than that, of course. We can give a person an insulin pump, which essentially is mimicking the 2 processes. It's containing about 300 units of insulin. All right, the person's attached on the other end with a little bit of a plastic catheter infusion set. This clips on, and then essentially this is programmed to go drip, 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 drip 24 hours a day. Of course, it's programmed beautifully to match the pattern of glucose that the liver gives out. And then when the person eats, they push a button and it delivers the insulin that they need for the food. Again, it's programmed so that it will deliver what they need for a banana, what they need for a piece of pizza. All right? So we can do a very nice job of imitating the pancreas. I present this to everybody. In New Zealand, these are not subsidized. They cost about $8,500. I believe that it is the right for anybody to know everything that is available to them for taking care of their diabetes. After all, who am I to know what they would like to spend on their health care? And to my utter amazement, I'm amazed, you know, they might quit smoking, the whānau, the family, come together and pay for something if they believe that it's the right thing for their kid or for their partner or whoever. Please present all the information to your patients. I've really honestly not added on a whole lot of detail to you guys. They get the same information, and my attitude is that one of the biggest barriers that we've got to diabetes care is because we make assumptions about people sitting in front of us. And we therefore limit the information that we're giving them. And my attitude is, if they can drive a car, if they can operate a cell phone or an iPad or whatever, they have every ability of understanding this. And I think my favorite part of seeing a patient is presenting this picture, because it doesn't matter how many years they've had diabetes. They are sitting on the edge of the chair at the end going, oh my gosh. And then you know what they ask? They go, so what is my physiology? That's the subject of the next talk. How do you figure that out with them? Any questions? Find your own way of presenting this to the patients. You're welcome to use this way. It's not the only way, okay? I found it works really well. Use it as your basis. I hand the picture to the person. It looks like a mess by the end of the time I've had with them. They love it. They put it up on their refrigerator door and they go over it with their family members. But make sure you bring it back, please, the next time. First of all, I can't remember what I've told you. All right? And secondly, we're going to keep on adding and adding to this picture. And any time we get to a point where we're stuck, we aren't progressing, I'll pull that picture out again. What is the bit that they're not quite understanding here? What is the bit that I haven't managed to communicate very well? All right? Find your way of communicating. Thanks very much.